Okay, well, let's get started. Good afternoon, everybody. Welcome to today's webinar, the Medicare Prescription Payment Plan. What new data tell us about access and costs? I'm Ken Thorpe. I'm the honorary chairman of the Partnership to Fight Chronic Disease and also professor of health policy at Emory University. We're grateful that you've joined us for this important discussion on the Medicare Prescription Payment Plan and what more we can do to ensure that seniors actually benefit from it. High out-of-pocket costs are a well-documented barrier to care, particularly for those living with chronic conditions. When people managing one or more chronic conditions can't afford their medications, they skip doses, daily refills, or stop taking them altogether. This has consequences not just for the individual's health, but also for our broader healthcare system. This year, importantly, Medicare introduced a couple of changes to address this challenge. You've likely heard of them referred to conversationally as cap and smoothing. There's now a $2,000 out-of-pocket cap on what beneficiaries with prescription drug coverage will have to pay each year, and a new option called the Medicare Prescription Payment Plan that allows beneficiaries to spread or smooth out their prescription drug costs into more manageable monthly payments. The out-of-pocket cap is applied automatically. But because the monthly payment program requires seniors to opt into it, it only works if people actually know about it. That's where we're seeing the real problem. The Partnership to Fight Chronic Disease commissioned a recent public opinion poll that showed that awareness among seniors is alarmingly low of this program. This lack of awareness undermines the program's effectiveness and leaves many beneficiaries continuing to face financial strain, especially when facing high upfront costs or managing long-term conditions. Throughout this webinar, our panelists will explore and share ideas about what they can do together from a policy, advocacy, and communication standpoint to help ensure seniors don't miss out on a program that can make their care more affordable and more accessible. Well, let's start with an overview of the polling data, and then we'll turn to our experts for guidance on where we go from here. So the polling overview, as I mentioned, the Partnership to Fight Chronic Disease commissioned a bipartisan poll with two highly respected firms, Public Opinion Strategies and GQR, to better understand what Medicare beneficiaries know and don't know, most importantly, about this new program. We surveyed 500 Medicare beneficiaries with prescription drug coverage, either through Medicare Part D or a Medicare Advantage plan. In the first quarter of this year, most respondents participated online, but over 100 were contacted by phone to ensure we included harder to reach groups like rural communities and minority seniors. First, just to recap what's new in 2025. For the first time, Medicare is offering two major cost-saving measures. The first is the $2,000 out-of-pocket cap on prescription drug costs. As noted before, that cap is automatic. And once a beneficiary hits that limit, their costs stop for the year. The second, which is our focus today, is the Medicare Prescription Payment Plan. This allows beneficiaries to smooth out their out-of-pocket costs across the year in predictable monthly payments. But unlike the cap on out-of-pocket expenditures, the Medicare Prescription Payment Plan is not automatic. Beneficiaries must actively opt in, and that's where we're starting to see some of the challenges emerge. Well, let's look at what we found. And so let's look at some of the top line numbers here. The first one is particularly, I think, disturbing about the potential benefit to seniors here is that despite the promise of this new program, 3/4 of seniors surveyed said they had never heard of the program, little about the Medicare Prescription Payment Plan. This lack of awareness is even more concerning when you consider the potential impact of the program. Among seniors who spend more than $1,000 annually on prescription drugs, nearly half said they'd likely use the program once they learned about it. In other words, when seniors understand how the program works, they see the value in it. but right now, too few even know it exists to make it really effective. So how do we improve awareness and uptake? We also asked respondents, who do you think should be responsible for informing you about this type of program? And our responses that we received were mixed. Most people pointed to the Medicare plan itself or the Center for Medicare and Medicaid Services. But some also highlighted healthcare providers, family members, and even pharmacists. This suggests there's no single trusted channel and that we'll need a multi-pronged strategy to build awareness and drive enrollment. So how can we do better here? And so how can we ensure that this promising new option reaches the people who need it the most? Well, that's exactly what our panel that we have here today will explore, how organizations, advocates, policymakers, and care teams can help bridge this gap. With that, let me introduce our panelists. And we have a really good group of panelists to share their views and insights about this very important program. And I want to thank them in advance for participating in our webcast today. Adina Lasser is our first one. Adina is the Director of Public Policy and Government Relations at the Alliance for Aging Research. Prior to working on the Alliance Public Policy and Advocacy team the last 3 years, she also worked for the American Urological Association and CRD Associates. Her background is in health policy, patient advocacy, contract lobbying, and my favorite, health economics. Adina holds a degree in economics from the University of South Carolina. Our next participant is Jennifer Dexter. Jen is the Vice President of Policy with the National Health Council, where she helps her groups and her member organizations establish policy positions that seek to improve the lives of people with chronic diseases and disability. Her work often includes visibility on Capitol Hill, where she further advocates for critical healthcare reform policies with key lawmakers and representatives from the executive branch. In previous roles, she has worked with the Congress to create and strengthen public policy affecting people with disabilities and older adults, particularly in long-term services and supports. Jen earned her degree in political science from Washington University in St. Louis. And finally, we have Patrick Wildman, who is the Senior Vice President of Advocacy and Government Relations for the Lupus Foundation of America. In this role, Pat is responsible for developing and implementing strategies to advance the foundation's federal and state legislative and regulatory policy priorities, and leading the foundation's interaction with government officials and agencies and grassroots engagement with lupus advocates. Pat also leads the foundation's work in managing the MAPRx Coalition, a group of more than 60 national patient organizations focused on Medicare Part D. He has over 25 years of legislative and regulatory policy experience in Capitol Hill and in the patient community advocacy community. He received his degree from Dartmouth College. So let's get to our expert panelists and let's get the discussion going here. So first, just to start off, I'd like to give each of our speakers today a minute or two to level set and share why their organizations are interested in this program and the value it adds for Medicare beneficiaries managing chronic conditions. We'll start with Adina, then Jennifer, then Patrick to set the stage before we dive into some more detailed discussions. So Adina?
Yeah, thank you so much, Ken, and thank you to the full PFCD team for having me today. Just as a little background, the Alliance for Aging Research is a patient advocacy organization, and our goal is to change the narrative to achieve healthy aging and equitable access to care. And the Medicare prescription payment plan is something that we at the Alliance have cared about for a really long time. Allowing beneficiaries to smooth their costs over the course of the plan year is something that can be the difference between getting your prescription at the pharmacy counter and having to forego it in favor of getting your groceries or other aspects of day-to-day living. For many older adults facing high costs, having that predictable monthly bill is so much easier than having to just pay everything upfront in January until they reach that $2,000 cap. But as you've mentioned and alluded to, the program only works if people are using it. And so the numbers you presented today, and I am so impressed with the PFCD team for all the polling that you've conducted, are concerning. And so we hope that CMS and Congress will work together to ensure that this program functions as it's intended to and actually is able to help the people that it's intended to help. Oh, Jen, I think you might be on mute.
Trying to be polite and mute myself. So thank you, everybody. Thank you to the PFCD team for having me here. I really appreciate it. The National Health Council is an umbrella organization of the patient advocacy community. We are led by and focused on those groups that are patient groups, much like PATS and ADINAs who are members. We also have membership from providers and caregivers groups and insurers and others to bring the full kind of spectrum of the health policy ecosystem together to create things that work for patients, but always led by patients. And I think that's where I'll start today is the idea that consumers and beneficiaries would have some, as Adina said, some predictability, some accountability, some ability to budget and count on things is really important. I had the opportunity to listen in on a lot of listening sessions for the Medicare drug price negotiations. And one of the patients that really stuck with me was a woman who had been on the drug they were negotiating for a really long time. And she talked about it. And she said, when I had this under my employer, I was paying $700 out of pocket. Once I retired and moved to Medicare, I was then paying like $7,000. So the difference, that difference kind of just shook me, and realizing that we're kind of bringing the Medicare program into the realm of how insurance should and does work for many of us. The idea of smoothing is something we have championed for a really long time, along with Pat and others. But the idea that added level of predictability and ability to budget, I mean, we know, very outdated term, but many seniors live with fixed incomes and predictable Social Security and pension and other checks. The ability to spread that $2,000 out will make a huge difference for everybody.
I want to jump in and also thank Ken and PFCD for bringing this group together and talking about what is an extremely important topic. And for people living with lupus, this has been a priority for us at the Lupus Foundation since the outset and advocating to make it possible. And in our interest, and lupus is a chronic autoimmune condition, and 90% of the people living with lupus are women. And the disease disproportionately impacts women of color. But one of the challenges with lupus is that it's different in every person. On average, a person living with lupus takes about 8 medications, but many others can take up to 30 medications. We just had our Hill Day 2 weeks ago, and we had patients going into congressional offices and with big bags full of the medications they take. So affordability is a huge challenge and a barrier to care and access to care for people living with lupus, which is why smoothing and the ability to spread costs out is so important to our community, as is the out-of-pocket cap. And at the same time that the foundation did establish the MAPRx Coalition back in 2006 at the outset of Medicare Part D, just as the program was being implemented. And since that time and throughout that time, our focus has been as a coalition to fight to make sure that Part D is serving the needs of Medicare beneficiaries, whether they be seniors or those living with chronic conditions who are in the program through disability. And we, as a coalition, we have about 60 groups, including Alliance for Aging Research, including National Health Council, who are members of the coalition. But it's really a broad representation of the patient advocacy community. And we bring the community together to educate about different issues. and including this one, and to advocate on those issues, in both with the Hill as well as with CMS and other stakeholders. And this has been, oh geez, over the past 3, 4 years, been one of our top priorities. And now it's great that we're in the implementation phase, and that it's out there and helping people. And the challenge, as Ken noted in your opening, is not enough people are aware of it, and aware of the benefits that it can provide, and ultimately help improve the ability of people to access the medications and treatments that they need.
Well, maybe we can follow up on that last point that Pat made. So among our panelists, what do you think are the main reasons why so few Medicare beneficiaries have heard about this really important payment plan? As we've noted, despite the potential to really make out-of-pocket costs throughout the year much more predictable and affordable.
I can start. I think there's a couple of reasons. The first being that while it seems relatively simple in the implementation phase, this is actually a fairly complicated program, not for the beneficiary, but on the CMS side of things. And I think when they've put out their materials, they've been in that sort of like high level lawyerese kind of language, which is hard. I mean, I work in health policy and I sometimes find it hard to understand. And so for the average person reading through it, there's just a lot of hurdles to going from no understanding of this to actually being in the program. And one thing that I wanted to lay out was, for example, if a beneficiary goes to the pharmacy counter and the pharmacist is tasked with telling someone who CMS views is likely to benefit from the program that they are likely to benefit and tell them a little bit about the MP3. So a kind of example of how that could go is someone goes to the pharmacy counter to get their medication, finds out then that it's that they're eligible for this program, goes home. We learned that it's about 90 minutes on average to enroll with your plan or to opt in with your plan to the MP3. Then you have to wait 24 hours. So you spend 90 minutes on the phone, wait 24 hours, and then go back to your pharmacy to go pick up the drugs that you tried to pick up a full day ago. A lot of people, that's just too much, especially for those who are managing chronic conditions, who are dealing with mobility or cognitive impairment, uh, or somebody who has a caregiver who has to take time off work to take them to the pharmacy counter. That's just a number of hurdles to actually getting first understanding and then being able to use the program.
And I'll jump in, and I agree 100% with everything Adina said, and it is there's a barrier to awareness of it, or a barrier to access it in terms of not being able to get to it at the point of sale. But one of the fundamental reasons, and all of us have argued with CMS about this, is the name. I mean that, like, quite frankly, that is one of the challenges. We have MP3, M3P smoothing Medicare prescription payment plan, which doesn't sound all that enticing. So I think that's been a challenge, and it's hindered some of the communications. And I think it underscores, the fact that we have low awareness. It underscores the need for all stakeholders who are involved in this, whether it's patient organizations like us, or whether it's the plans, or whether it's CMS. And Ken, you highlighted this in your slides. There's multiple different stakeholders that are involved that need to, or that can do more to educate beneficiaries and raise awareness of this. And then the next step is, how do we facilitate opt-ins, with people electing M3P when it can benefit them. But it's really I think a big challenge is just getting the word out, and making sure that we're doing that where people are at. Whether it's at the pharmacy counter, whether it's at the physician office, whether it's in engaging with patient organizations that they work with on a daily or weekly or monthly basis, and making sure that those different audiences are communicating this information and the availability of this important benefit. And that, I will say too, I think one of the groups that can help get the word out are members of Congress, and their staff, especially in the state and district offices, and they're interacting with constituents. And this is something I think we've been arguing, and we're not arguing, but we've been encouraging them to promote it within their own constituency. So a lot more work needs to be done, but I do think that one of the biggest challenges was the name itself.
I 100% agree with Pat and Adina, not surprisingly, since we work so closely on this together. I do think one thing to be cautious of is to be somewhat patient. This is an entirely new mechanism within Medicare. We have made some of the numbers I've seen, we've at least made progress since last open enrollment, a few percentage points, but there is progress there. I think that will continue to grow as the year goes on and people begin to hit higher and higher, they go for that fifth refill or whatever. We'll get more information out that way. And I just feel like we need to realize that, like Adina said earlier, like most things, people are not always the most planful with their healthcare. Not for bad reasons, just that's human. And it's not currently available right where you need it. Can't make those decisions on the spot when you get that bill. The biggest thing I compared this to at the beginning was kind of when you go buy furniture and there's no interest down for a year kind of thing. You can spread the cost out for the year without interest. It's obviously slightly different, but that idea, I only know about that when I go buy a couch and somebody says, hey, you want to spread the cost out over the year? And I do it right there. And that isn't currently available with this. As Adina said, you have to step away, you have to make a call, you have to talk, dealing with your insurance company is not anybody's favorite thing. And even if they are successful in that, the odds of them kind of coming back for that refill will have an impact on adherence and fulfillment. The other thing I've kind of been watching is the idea that Medicare beneficiaries are going to be inherently suspicious or cautious on any Medicare issues. They are so attuned to all of the Medicare scams that kind of, those phone calls you get and those emails you get, they're kind of conditioned to be suspicious of new things, of things that sound too good to be true. I do think we have a barrier to overcome that a little bit. And that gets to kind of the next issue, which is kind of who are your trusted messengers and how do we get to them in ways that they'll actually listen to?
Yeah, and just last thing, I completely agree with everything Pat and Jen said. Last thing is that CMS has set that likely to benefit threshold at $600 for a single prescription. So even if all of your prescriptions together reach that $600 limit, you're not going to get that unless it's one prescription that hits that. And so it does seem like that's kind of an unnecessary burden and barrier to care where someone with multiple prescriptions or someone hitting that $600 threshold or even slightly lower could benefit but isn't getting that notification for that reason.
I agree. I think that is one of the reasons why there is low awareness is that the outreach that was conducted was targeted just to people with above a certain spend, and as you pointed out, Adina, and people with lupus, they may not hit it with one script. That trigger that would trigger someone to get a notice that this is an option for them. People with lupus may not get that with one script, but they might get it with multiple scripts. And they could benefit from it. And that is one of the reasons why people haven't heard about it, is because of these limitations on who CMS and the plans are reaching out to.
That idea of most likely to benefit, I think, is a real barrier in some ways. I get why you do it because you need to target resources where they'll be most impactful. But so much energy and thought went into kind of trying to define that and send it. And, probably could have devoted all of those resources to making sure everybody knows across the board. But that's Jennifer speaking.
Well, here's another cut at this. We've been focusing on, and we'll come back to this in terms of how we can enlist trusted messengers, such as the group sitting around the table today talking about it, and others to make this program more available and to make sure that beneficiaries are aware of it. So that's really on the beneficiary / advocacy side to make people aware about this. I'm just curious about your thoughts and thinking about what type of administrative flexibility under law does CMS have to make this easier for patients to sign up. So for example, I'm just throwing this off the top of my head, when you sign up for a Part D plan,
Check a box.
there's a box there saying that you want to opt in for this program, or you sign up for an MA plan and you get a Part D plan associated with it, that there's a opportunity to sign up then. Are there administrative options that we would have to really, as people sign up for these benefits, so make it a possibility to say, well, yes, I want to opt in or not opt into this opportunity?
Go ahead,
know,
Ken. Oh, we're sorry.
I think
Yes.
any one of us, all of us have had this discussion. The one thing that actually is a good thing that was done, that CMS has proposed for next year, is allowing people who've opted in to continue to stay in, which is really good. And previously, it was you had to opt in every year. So that, I think that's a good development. Certainly, some of the things that we've already mentioned in terms of a point of sale option, being able to opt in at the pharmacy counter, or when you're signing up for your plan. I mean, those are I think the two biggest things that can help with the uptake of this across the board. There's certainly a lot of other things, but I'll defer to my colleagues.
They have a lot of flexibility to be able to do a lot of that. A lot of these are choices that have been made along the way for very real reasons, for very real bandwidth and feasibility and political reasons and lots of different reasons. They've made a lot of decisions. That is all within their rights, I guess. Yeah, I think to be able to do it that way. I do think, yeah, it sounds simple, like check a box on an insurance form. Insurers are not the most trusted messengers. People are going to look at that, assume there's some sort of additional fee or some sort of interest or some sort of issue they could run into if they chose to do that and missed a payment, those kinds of things. So we kind of have to hit them from multiple fronts, because that trusted messenger is going to be different for everybody. So making it easier to sign up, that is absolutely priority one from my point of view, of making it kind of automatic and insured, but pairing that with making sure that people have the information they need from the right people at the right time.
I totally agree with that. And one other thought that I had is that there's currently no overarching tool for signing up. Jen mentioned to check the box, but each
no matter what plan you pick,
yeah, each plan has a different form and a different process for how you enroll. And so even just synthesizing that and making it a little bit easier on the beneficiary to find, maybe on the CMS website or, on the, something like that, just one universal tool for opting in, that can make a big difference as well.
That's a great idea.
Yeah, and also like picking up on the trusted messenger that Jen had mentioned is all of us and who work in patient advocacy and work for patient organizations, and we're trusted messengers, as are the people that we serve, in terms of in our case, people living with lupus. And so what we're trying to do is really arm people with information. So whether that's patient organizations, so MAPRx Coalition has created some resources, a guide to this, to M3P and what it is, how it works, and how to decide whether it's right for them. And that guide is most people outside of DC have never heard of MAPRx, but they have heard of the Alliance for Aging Research, or the National Health Council, or the Lupus Foundation of America, or any number of other patient organizations. And materials that we've created are fully customizable by patient groups. So patient groups can take those materials and make them their own. They can customize it so that it highlights the medications that organ, that patient community takes most frequently, and really tailors it towards that audience. So that's just an example of how we can, us as trusted messengers can get the word out to within our communities. But that's one of the resources that we have available for patient organizations to use.
We're kind of in the same boat. And I think one of the interesting things we did with our resources and our education and outreach activities that all these folks were a part of was now you can do such targeted pieces that was really helpful because we were able to reach Medicare beneficiaries. We were able to say, this is, this ad and this resource and this information is going to appear before Medicare beneficiaries, but also nurses and doctors that work with older adults. Like that was, you can find that and target it. And that was a really good opportunity for us to kind of, again, trusted messengers, right at the top. I mean, we absolutely are trusted messengers, Pat, the patient groups. But top of that list is your doctor. If your doctor says, hey, I know this is kind of expensive, you might want to look into spreading it out when you go to the pharmacy kind of thing.
Those are all really great points. And in addition, I'll just add, we had about a 4-minute video that sort of walked through what this is. And we put it out in Spanish, and we also put it out as a PSA in 1 minute and 30-second increments. And the other thing that I thought was really interesting is that, we didn't do it as the policy team. We had our health education folks who understand how to communicate with people who are not immersed in health policy in their day-to-day lives, how best it works for them. And I think that really made the resources a little bit more accessible. Yeah.
Just to answer a question, we all shared our resources, and my understanding is those will be part of the wrap up that you guys can get. So you'll be seeing all of that.
So on this theme of sort of trying to get the word out and making this more accessible, what opportunities are there for focusing on the caregivers, largely adult children, to maybe help their loved ones, understanding the program, knowing about its availability, and finding ways to help them to sign up?
Yeah, I think I'll beat you to it, Jen. So that's a huge audience. I know, speaking personally, I help my parents as they navigate this, and it's certainly confusing. And so I think that's why some of the resources that Alliance has and Health Council has and MAPRx has, and there are certainly others out there, making sure that there are things that are targeted towards the caregiver, towards the family members, that they have the information they need to help their loved ones navigate this. And we do have some of the materials I mentioned earlier. In addition to that, we do have kind of almost like talking points. And those can be used by not only a family member to help them have these conversations with a loved one, but also by a patient organization, call center, for example, or whether it's an 800 line or whether it's receiving emails that can respond to questions that can help guide those conversations, so that whether it is a beneficiary themselves or whether it's their loved ones, they can better understand how this might help them, and so that they can make an informed decision. And that kind of goes back to what we were talking about earlier in terms of some of the barriers to awareness, and that that people who are most likely to benefit, they were the only ones getting the information, and why we as a patient advocacy community, and as we look towards 2026 and more outreach and education that needs to be done, that we really recognize that this is really about making informed decisions and helping people understand that this is a benefit that's out there, that it may be beneficial to them, it may not be. But at least, let's inform the community, the broader community, so that they can make that decision. I think that's really, really imperative.
I think caregivers are really important, but at the end of the day, the information's the same. People need very clear, very direct, concise, actionable information that allows them to make the right decision, as Pat said. I think that's the conversation, again, I have with my parents, very much so. And I think that the idea of putting together the right information and doing outreach directly to caregivers, because they're also the ones who are going to be, because one of the things I'm a really strong advocate for in this is that as part of this process, you need to assess your own financial information. The government, we can't, others can't figure out what financially makes sense for you in your moment in life right now. And that's something that caregivers and spouses and children are very important in that conversation, helping people make those decisions about whether it makes sense or not. And that again, it comes back to the clarity and the actionability of the information we provide. They should be able to go on the Medicare, Medicare.gov site and get good information that makes it an easy conversation. Or to have the information you have to have what can be a complicated conversation. But I think that's really key. I think particularly for caregivers who don't live and breathe the Medicare piece every day.
The other one I'll just throw out there is the state health insurance assistance programs. We've all three of us have worked with them, and MAPRx did some focus group work with them before last year, before this was implemented, to get a better sense of what types of resources would be helpful for them as they work with beneficiaries and family caregivers. So that's another resource, a great resource to turn to, and that we always encourage folks to access, because they are, they're helping people navigate decisions like this one.
Well, let me stay on the go off track here a little bit, more on the administrative side. So we've done a lot of work in really highlighting the great work that your organizations are doing to really try to get the word out, which is very difficult in terms of just the background noise and the expense, and trying to find the effective vehicles for doing this. And we all applaud the organizations for doing yeoman's work at trying to get this accomplished. So we all appreciate all the great work you're doing. Well, let me just throw this out just as a food for thought. And again, it goes back to the administrative flexibility, or Lord knows there's so much going on in Congress right now. We don't want to add another sort of checkpoint here. But is there a case to be made that we have a automatic enrollment process with an opt-out provision, that if people really don't want to do it, they don't have to, but they just would opt out? But just like we have with the $2,000 out-of-pocket cap, which is automatic, we would have this as a automatic enrollment provision with an opt-out. Is that something that's plausible, feasible, or doable?
It's a really interesting question, Ken. It's not something that we have specifically advocated for, and I'd be interested to hear what my fellow panelists think. I do think, for some Medicare beneficiaries where they have, $25 costs, it might not make the most sense to have them automatically enrolled. But, I think there's definitely some argument that increasing awareness and having people decreasing the barriers to opting in is maybe the course that we've been thinking through. But curious what Pat and Jen think.
I 100% agree with you, Dina. I think I might be a little bit of an outlier on this, but I think the automatic opt-in, I think of my parents again, as most people do, and they kind of have these conversations, could be more hassle than it's worth. So they're not gonna, I have read something once where they were like, if you do an opt-in, do you want to get punched in the face? Like 90% of the people aren't going to opt out because they're just not going to do it. So I do worry a little bit about that, and would prefer to focus on getting the good information out and streamlining and easing the process to enroll. You should be able to make that decision in a moment. Your pharmacist should get you quick and easy information at the point of sale. Put all that together, you get the right people and a lot of help making decisions. I don't know quite what the right answer is, but I think there's kind of things to think through on both sides of that.
Yeah, and I agree, and I think it goes back a little bit to some of the work that we did before this was implemented, and just when I think about the lupus population in general, everyone's different, and so whether it's different medication needs, different resources, different preferences. So yeah, I'd be cautious about an auto opt-in. This was some people do want to, if they have the resources, to to hit that cap earlier in the year without spreading out the costs. Others may have lower drug costs, where, as Adina said, it may not be the best option for them. Still, others may be eligible for extra help, and that may be the better choice. It is the better choice. So, so I think having the flexibility is important. But then going back to what we were talking about earlier, where there is this, it's not an auto opt-in, but it's an automatic. It triggers information, and that's at a certain threshold. I think that that threshold needs to be much lower, or eliminated altogether, because that's about information. Right now, we're limiting people. It's not even an issue of opting in. We're limiting information about this,
Yeah.
and I don't think we should be. If we want, if we truly want people to benefit from this, we need to make them aware of it, and reduce those barriers, and then eliminate the barriers to opting in.
I also do think it would put a lot of strain on the plans, and I worry about how they would try to recoup those costs. And if they're going from getting the payment at the pharmacy counter to getting the payment at the end of the month for all of their beneficiaries in the Medicare program, I wonder how they would go about trying to uh, mitigate those concerns. So
Yeah.
Well, let's keep on sort of the opportunities for making this more effective and more widely known. So we've talked a lot about the strategies that you guys and your brother and sister organizations are doing, and what the opportunities are there. So I'm not going to let them off the hook here, just to throw it out. But in order to make your efforts in working with caregivers and adult children more effective, what, if any, role should Congress play and CMS play in promoting awareness of this program to make it more widely known and easier to enroll, that would really help your efforts? It would complement some of the things that you are all talking about.
I think it goes to, and Adina and Pat might disagree with me on this, but I think there's so much focus on finding that most likely to benefit population that we're missing the broad brush, like high level of awareness to help people make their own decisions. So I think pushing point of sale enrollment, I think Congress should be working with CMS to help support that, put appropriate resources behind it, and not just say, like, point of sale, it's too hard, we can't solve that problem. Yes, you can. You just need the proper kind of push and energy and political will.
yeah,
And
oh, go ahead.
actually, I'm going to turn it over to you in a second, Adina. But I think there's a couple of things, and one is Jenna, the resources needed to promote this. In my view, having been around when Part D was first implemented, and seeing the level of resources that went out, that CMS dedicated to getting the word out, to educating people, to informing them of the availability of Part D, and then look at what was done for this, it's night and day. There was very little done. So that's one thing. But the other thing, and this is where I'm going to really turn it to Dina, is data. We need to see who's opting in now, who's not opting in, what are their spend, and that's going to help inform our outreach, and help inform which audience do we really need to focus on. Who are we missing in this group? And right now, we don't have that data. So
Absolutely.
I'll let Dina talk more about that.
Yeah, no, we had definitely had a mind meld, Pat. Yeah, absolutely. I think the data is incredibly important. The kind of data that PFCD is collecting can tell us so much, but really the data that we need is from the agency. Who is actually using this program? Who's opted into this program? Are there areas of the country where we're seeing less enrollment than we expect to? Are there populations, rural, urban, different minority groups that we're, seeing under enrollment from. And then not only can we ask Congress and district offices, especially, to reach out to their constituents, can we ask the program to make the kinds of changes that we've been talking about this whole time? Um, but we can also help to tailor our messaging, and we can, Jen was saying that we can really be specific with our social media advertising and how we get this message out. So if we know what groups we're seeing under enrollment from, we can push it to those groups, and we can make sure that they're seeing the materials that, all of our groups have spent a lot of time putting together. We actually have appropriations report language in the Labor, Health, and Human Services appropriations report that we're asking Congress to implement, which talks about having CMS report quarterly data so that we're more aware in real time of what's going on when it comes to enrollment.
Mhm.
Yeah, and I think this is one of those things where Congress can just follow up on this program that they've asked the agency to implement and make sure that it's being implemented in such a way that it benefits the people that there was congressional intent for it to benefit.
Well, on that front, you've all been around Capitol Hill long enough and to see the transitions and a lot of the
Mhm.
fluctuations in members and staff. I wonder too on that front. Obviously there's a lot going on in terms of some of the big pictures with respect to budget reconciliation and some of the large overarching issues going on. I wonder how much of an opportunity there still is to, and I know I'm sure that certainly the staff on the relevant health committees are well aware of this, but really at sort of a broader level in terms of just the broad staff turnover, the broad congressional turnover, how much of an opportunity there still is to work with members and staff to make sure that, and it may be a silly thing to say, that my sense is probably a lot of people don't really even know about this on the congressional staff level and even on the congressional level. And you would think that, I get my newsletter from my congressman about all the advocacy work they do on behalf of the beneficiaries. And if you need help with X, Y, and Z, please contact my staff. This might be a real opportunity here at a member level and at the staff
Mhm.
level to say that, gosh, in your weekly newsletters that go out to your constituents, just even having something like that saying, if you want to learn more about this program, you can contact my office or contact one of my staff just to find out more about it and how to get information and to see if you're interested.
Yeah, there's a reason during open enrollment, we sent all of the materials that we put together to the entire Congress's congressional services staff. 'Cause those are the folks that get the calls of help me.
Mhm.
Yeah. There are all sorts of interesting ways, but you're absolutely right, Ken. There's a huge education lift still to go in kind of continuing to keep this front burner. Um, the IRA, for better or for worse, has become contentious. And so we have to be careful within that kind of environment. But
Mhm.
I think this was the one thing that a lot of members of Congress hung their hat on when the IRA passed, was that for the first time people were going to have cap and smoothing. And we need to continue to work with them to kind of hold them to that.
Yeah, and I agree. I mean, this is a victory for everybody. It's and both sides of the aisle. It's nonpartisan. It's not political. It helps constituents. So yeah, there's always a need to continue to get the word about out on the Hill, to educate them. This is a plus to include it in the newsletter, or to
Yeah.
have resources available in the district office that you can make available to constituents. I think there's always a continuous need to educate the Hill for precisely the reasons that you mentioned, Ken. I mean, there's staff turnover. There's a million different distractions right now, and so we always need to go up there to do that. And I know all three of our organizations do some varying forms of Hill briefings, where we educate staff about the differences between Medicare and Medicaid, for example. And so there's always a need to continue to do that. And I know the three of us and many others are committed to doing that this year and giving the resources to the Hill to help them better serve their constituents. And ultimately, that's really what they're looking for.
Yeah, I think you guys said it perfectly. And just highlighting where we keep mentioning the district offices because those tend to be the offices that people call when they have questions. And they're doing that more like direct to constituent outreach. So that's been a really important piece of the strategy. And it has always been funny to me when you go to the Hill and you're talking to a staffer and you might be having an incredibly in-depth policy discussion, or you might be, as Pat alluded to, saying, and here's what Medicare is, right? And here's who it serves. And so, absolutely, I think there's a lot of benefit to educating on the Hill. But I do think when we have gone in and had these conversations, it's been overwhelmingly positive. Overwhelmingly, this is a program that we want to keep pushing, that we want to make sure is implemented in a way that benefits people. I haven't had any contentious conversations on the M3P. So I do think that we're in a really good, warm spot with this program, and that, even at CMS, we've had great conversations over there too. People want to work together with us and with the broader patient community to make sure that this is implemented well.
And I think this one other thing on this, because there's so much noise out there, there's so many different issues and some really, really big issues, some smaller. We need to make sure we want to get the word out, not only to help improve the program, but to strengthen it and support it and make sure that, God forbid that someone doesn't try to repeal it or take it away because there's so little, the uptake isn't where anyone expected it to be. So we need to continue to promote it, both for the real reason that there's a lot of people that aren't benefiting from it that could, but also make sure that this policy, which is a good one, continues. So that's another reason because who knows, there may be efforts to get rid of it. So we want to make sure that it has the opportunity to succeed.
So I always try and think through like the generic person, like when you go and you're shocked at how expensive something is at the pharmacy counter. First thing you do, yell at the pharmacist. Second thing you do is call your doctor. Third thing you do is call your insurance company. Then you call an advocacy group, and then you call Congress. Like we need to make sure that all of those folks are like singing from the same songbook, sharing information as clearly as possible, and understand how this works. Not just awareness of it, but really understand how it works.
Yeah, and there's definitely a lot of resources out there for that precise thing because it isn't right for everybody. There's certain people that it may not be the best decision for, but it can be on the kind of the back end be a little confusing. And I know there's resources out there, whether it's MAPRx or Alliance or Health Council, that can help people answer those questions, and help people navigate it through different scenarios, whether you have one expensive drug or multiple, less expensive drugs, whether you opt in at a certain time of the year, during open enrollment or later in the year. So there's definitely resources to help people make those decisions.
And
Let me
please
see.
don't yell at your pharmacist.
Yes.
Or pharmacists. Well, let me just ask our moderators. I didn't know, did we have any questions from the audience at all that we want to address or? Well, if not, why don't I go ahead and turn it over to our panelists, just sort of get their closing thoughts here, and just end with just a brief 30-second sort of closing remarks. But if we get your final shots at parting wisdom here about how best to proceed and where do you see the gaps and what can we do over the next several months to make this as effective program as possible?
Well, I think, I'll start. I think conversations like this are a great start, and really cooperating between advocacy groups so that we're, working together to get the message out there. I've so enjoyed working with Pat and Jen on this and a number of other groups, Pan Foundation, PFCD, has all been amazing, but wanted to shout out those two specifically. And Also we're doing this advocacy on the Hill and with CMS. And if there are any other groups there, individuals who would like to do that work with us, we would more than welcome that and encourage you to reach out. So thanks so much to PFCD again for the time. And yeah, I'll pass it to Pat.
Yeah, no, I agree, and thanks for the Adina there's many others that have been involved in this. PAM Foundation is certainly one of them. In addition to PFCD and the three of us, a lot of groups have been involved, and I think it's also important to take advantage of the resources that are out there. Whether it's MAPRx or Health Council or Alliance or PAM Foundation or others. There's no need to reinvent the wheel. This is kind of get into partnering. There's a lot of things out there that can make it easy for groups and individuals to get the word out and to help them, help beneficiaries take advantage of this. And then, like I said earlier about, we need to continue to advocate for this program, whether it's with CMS or the plans or with the Hill, and improve awareness of it and then make it easier to opt in, whether that's a point of service option or point of sale option or via website. We need to reduce those barriers. But none of that can happen if we stop talking about it. So we need to continue to talk about this with all different stakeholders, the Hill included.
Yeah. I think, last year when we were going into the first cycle of this, and I remember we were all kind of, Pat had resources and Adina had resources and we had resources, and it was like, oh no, are we, reinventing the wheel? It's like, no, there is plenty of work to go around here in getting the word out about this new program. And I think we did an amazing job. I think there is so much more to do, and it is all hands on deck to continue to educate people and help people understand. And that comes back to, again, clear and concise, actionable information, and ease and streamlining of participation.
Well, all good pieces of advice. I want to thank our panelists, Adina, Jen, and Pat, for joining us today, and more importantly, for all the wonderful work you are doing and continue to do on the Medicare prescription payment plan. As we've seen, it holds real promise to make for some medications more affordable and predictable. I think that the polling and what we're hearing from our panelists is that the polling we saw really underscores the urgency of this challenge. A lot of seniors still are not aware of the program. Many of those who learn about it are really interested in using it. So as we look ahead, we all have a role to play. I think the Congress, CMS, all of our chronic disease and patient advocacy groups, adult caregivers, really has to be a multifaceted effort here. We at PFCD will continue to spotlight the solutions and continue to convene groups like this to find ways to reduce the burden, both in terms of healthcare treatment and costs of chronic disease, and find ways to strengthen access to care. So again, we're all grateful for you being a part of the effort. Thanks for the three of you for joining us. Thanks for those of you in the audience for joining us as well. And we certainly want to enlist those in the audience that can help in the effort here to chip in and find ways to collaborate with these very, very effective and good efforts that are already ongoing. So if we can build more coalitions from a meeting like this, from people that were listening to the webcast today, all the better. So again, appreciate you all joining, and we look forward to continue to work with all of you in solving some of these important problems. And gosh knows there's going to be many more downstream to come. So thanks for the advocacy that all of you have and continue to put forth around the issues of access and patients that have chronic healthcare conditions. And with that, have a great rest of the afternoon, and thanks again for all for joining.
Thank you.
Thank you.
Thank you, Ken.